So we'll get as soon as Ingrid gets back. But so we're going to talk about baby-friendly documentation, and I want this to be a more interactive session so that you guys want to hear from what y'all are doing. Some of you that obviously we've gotten examples, so I'm going to call on some of my friends like Jeannie and Angela and so forth that have sent us some examples to kind of walk through, because I think one of the challenges with documenting the required elements or anything really related to breastfeeding is that we have two patients. So where do you put stuff? Do you put it on mom's chart or baby's chart, and how do you chart that at make it so that the workflow for the nurse is easy and that it's going to consistently happen? Or is this something kind of extra special they have to document, so then what you need documented doesn't actually get done? So there's Ingrid. So shall we, I think just maybe, we had a first 2 or 3 slides just to kind of run through what some of the required elements are. And those of you, I know we've got our Integris crew here, so you've just been through your assessment and all. You can certainly share if any lessons learned on your assessment. Excuse me here. Just go ahead and do this. If that will work or not. See how does that? This just never gets up. There we go. Maybe I might hand this off to you as we have other people too. Yeah. So I'm gonna try to. There we go. Or not. Come back. That is sensitive. Okay.
There's that thing too that we'll take it.
Oh, let's do that. Oh, yeah, let's do that. I like that better. Okay. So, so those of you, as you're participating in our state project, our Becoming Baby Friendly in Oklahoma project, we do ask, as you get a little further along in your journey, not in the first few months, but certainly after the first 6 or so months of your progress, that you start collecting some really basic elements. These aren't all that are required by Baby Friendly, but at least many hospitals often aren't collecting some of these elements. So we would ask that you report to us your rates of any breastfeeding along the lines of the Joint Commission core measure that Dr. Winter mentioned or went through, that your rates of exclusive breastfeeding, and then skin-to-skin percentages both after vaginal and cesarean deliveries, and then periodically staff and physician education. So Ingrid, you want to share with us how is that reporting going? I think that's been a challenge to get.
It can be challenging because some people are, they're not clear on exactly what they should be reporting to us. So as far as, well, this baby didn't go skin to skin right away, but the APGAR was 4. And so they think that counts against them. But it's no, if everybody's stable and those sorts of things. So that's where some of the challenges come in. So we're looking at things that don't count against you, or things like if the baby's late preterm or things like that, that we don't count that. We're looking at healthy term babies, either VAG or C-section. And VAG is within 5 minutes, within the first 5 minutes. So if you take baby to suction meconium or something, as long as they're back within the first 5 minutes, you've met that measure. And C-section, as far as the wording from Baby Friendly USA, is as soon as mom is able to respond. So we'd like to see it in the OR because most moms are responsive. But if you have a crash C-section under general anesthesia, we're not going to penalize you for that because that's not a normal experience. So we're looking at normal experiences of healthy term babies. And that's where we get into there. So the breastfeeding documentation. So this is also something that can be a point of kind of some muddiness. So any breastfeeding, will you go back?
Oh, sorry, go back.
Okay. So any breastfeeding is, did the baby ever go to the breast? So was it that mom was like, oh, I think I'm going to bottle feed, but when you put them skin to skin, okay, I'll latch on, but then the next feeding they say, yeah, I don't want to do that. That's any breastfeeding. Okay, but if you have a baby who mom comes in and says, I want to exclusively breastfeed, and then baby has a medical indication like Dr. Winter just covered, that doesn't count against you. So if baby is greater than 10% weight loss, hyperbilirubemia, non-responsive glucose, and they have to have a one-time supplementation, you still meet that core measure of exclusive breastfeeding. We're talking about the people that are getting supplementation for perceived insufficient supply or non-medical reasons. And that's where that's where those are teachable moments, where that's an opportunity for education as the intervention instead of, oh, let me just go grab you some formula. So that's where it counts against you, is if you're not doing the teaching, instead you're just going to the Pyxis or whatever. Well, I guess nobody said they were locking it up. So wherever you're keeping your formula.
Yeah, question here.
Does it still go against you if you document that education, though, and the mother still chooses to offer formula?
No. I mean, it does as far as if it needs to be that's where there's some muddiness there, which we're not clear, is that it's that maybe the education wasn't done, or maybe wasn't done completely, but the nurse documents it was charted, but then the mom says, I never received any education on that. So what some hospitals have done to meet that measure, this is part of the PCO5 core measure, is they've had a documentation like informed consent, like you do with an epidural or something, is that, yeah, we're happy to do it, but we just want you to know we've counseled you about the risks. These are the risks in paper. Sign here and we'll get you your formula. That's where you can kind of fix that, because that's where we're getting it into, is that the mom is reporting something different to the assessors or to someone else than what is actually being done.
I think I think that's where some of the confusion comes in, because the difference between what the Joint Commission core measure requires, that might count against you as far as that's not an exclusively breastfed baby anymore as far as the core measure is concerned. But when the baby-friendly assessors walk in the door of your hospital and interview the mom, if the mom says, yes, I asked for formula, they discouraged me, they told me it was going to make breastfeeding harder or impact my milk supply, and I still wanted it, that would not count against you. Does that make sense? Wouldn't you guys, Integris folks, agree with that? It's a hard one.
Yeah.
Your mothers saying that they didn't get, they need to be able to verbally say informed consent. If they all say they don't have it and it's just a bunch of signatures, that's not going to get it. It needs to be your mothers being able to say, my baby's blood sugar was low, they need to be able to say the reason and that they agreed to it. They have to agree to it.
Informed consent, giving the mom the opportunity to write in her own words that she understands what she was educated on.
One of our charts, because we made sure our moms were prepared.
Right, but to speak to that, not just for so we don't want to just encourage practices that kind of teach to the test. We want to make sure that we're changing the dialogue that we have with our patients so that they have a good understanding. So it's not just, yes, I can answer this question whenever the surveyor comes in, but do I really know what the risks are so that I really understand? No. I'm not saying you are. No, I wasn't. Right.
Exactly.
Right. And that's where we see that, is if people are consistently doing that, the moms can answer the questions. But it's
and the whole goal would be that as you put those pieces in place, that you would actually see those requests decline. As moms really understand, then they're going to say, oh, well, maybe I don't want to do this after all. And so you see your supplementation rates go down. I mean, that's the whole point of tracking, collecting the data and reporting it, so it helps us know from the state project and the health department standpoint, what else do we need to do to help y'all turn those numbers around. And then it helps you know, well, we thought we were doing good over here, but over here, why do we still have so much supplementation? Why do all of our babies, or an awful lot of our babies, seem to have hypoglycemia, or whatever the reason is? It gives you something to then go back and take a close look at what else needs to change. So shall we move on? Yeah. Did you kind of cover...
I think we covered. Do you guys have questions on skin to skin documentation needs to have a start time and a stop time. So, because some people, whenever we're looking at their data, where we can't include their data is they chart a start time and no stop time is listed. Well, we'd like to say that, oh, they were skin to skin for 3 hours, but maybe they were skin to skin for 3 minutes and the nurse just didn't check the box or whatever. And so we can't include that data.
Yeah, so time is really important. And when an assessor is in your hospital and they enter, it's all about what the mom tells them. And the documentation needs to either, actually, especially if the mom tells them something that conflicts with what the practice is supposed to be, then does the documentation support why that deviated? Does that make sense? So if the mom says, well, yeah, they put my baby skin to skin right away, but then, it was just for a few minutes, and then they took him off, and then it was 20 minutes before they brought him back. It's like, well, we really haven't changed practice. We did a token skin to skin, and then we still did all our stuff and brought the baby back, versus if the chart says actually the baby went skin to skin immediately and stayed there until he was 68 minutes old. There's a time in and a time out. Then the assessor will know, okay, that's well documented, but it's got to be very clear. And you'll see, we aren't asking you to report on rooming in, but it will be the same thing with rooming in. If the baby leaves the room for any reason, so this is where, when you talk about saving time and making a case for keeping the baby in the room and doing everything in the room, every time you take the baby out of the room, you need to document the time the baby left, the reason the baby left, and the time the baby came back. And that better be, ideally a medical reason. And so if every time you take the baby to do labs or to do the hearing screen or do the, the heart test, whatever, or the physician exam, you're doing a lot of documentation. You got to do your double ID. How much time does that take for the staff?
Well, the other thing I would say on that is that whenever they're looking at it, they're looking for rooming in they're looking for 23 out of 24 hours unless you have a medical test, like baby had to go downstairs for an ultrasound and it took 2 hours. Okay, but if baby was out of the room for 3 hours for hearing screen, routine labs, the surveyors are not going to be on board with that.
So the other piece we ask you to start tracking, of course, is the staff training, because that's what's going to help you start making the changes that you want to make, both for your nursing staff and your physicians, midwives, and so forth. So once you get far enough along in our state project, we like you to send, the clinical data in monthly. Staff training, maybe kind of as you do, we just did another round of skills labs, or we just did some more classes or whatever. So report that as you have updates. So we can also help see what support we need to offer you if you're struggling with staff training and need more resources with that. So I think... so this just kind of summarizes what Baby Friendly is going to require with, as we mentioned, the skin-to-skin, the exclusive breastfeeding, rooming in, and then really, as Dr. Winter mentioned already, any use of artificial nipples. They will ask the mothers that, and that needs to be documented as well. So we have a question over here. Okay. Ooh, that's a good question. They're not really tracking, some sort of breastfeeding device other than pumps. Our hand expression, they'd want to know if we've taught mom milk expression in some fashion when that's needed. But, yeah, that's a great question. But they're specifically right now looking at pacifiers and bottle nipples. So because that's going to limit feeding time at the breast, where hopefully a nipple shield, if we're using it for the right reason, is increasing feeding time at the breast. So, all right, I think we're ready. So, Jeannie?
This is Jeannie. This is Meditech, right?
Here, let me.
Denise and I got together and
Hold on.
told her what we needed. Oh, sorry. Denise is our educator for our hospital, so I kind of went to her and said, this is what we need to do, something like this. And so she came up with this, and it's very easy. I don't know if it was easy for you to put it in there, but it's easy to it's easy to document on. And our nurses do a really good job with this. It's pretty much all the charts I looked at. There was something on this that was documented, and this is in the baby's chart.
This actually is incorrect, though.
It is?
Skin to skin indicated, it actually says why was skin to skin not initiated.
It should be. It says not on ours.
This must be like an early version or something, but that box is to document any medical indication of why it was not done. Mom's request, or it gives enough characters where they can put in a fairly lengthy description of what happened.
Okay.
Like resuscitation or
Okay, or urgent transport to
Right.
NICU or something
Right.
like that, right? And this is something they're going to look at regardless of feeding status, because all babies should be skin to skin, and it's the way that it reads is until completion of the first feeding or 1 hour if they're formula feeding. So if they're breastfeeding and at 45 minutes they're done breastfeeding and the mom says, okay, let's see how much this baby weighs, you've met the measure. But if they're formula feeding, they need to be skin to skin for an hour. And if mom's not able to respond, skin to skin with a partner or support person.
Just since this is on everybody, it's actually tied to our delivery summary assessment. So it's on every single baby, every single chart. So it's real easy to get to.
Have you guys, did you guys find a way to get it to like auto-populate into both charts, or do you have to chart
No.
at both places?
We just charted in mom's chart. I mean, babies.
Okay.
I think we're looking at it from a lactation perspective too when we're charting lactation notes and trying to chart in both moms and babies. But I think that it doesn't have to be in mom's chart, but I think that's the challenge is, well, this piece is over here because it was the baby. Is it the baby that's doing skin to skin or is it the mom? But over here we charted that we educated the mom about the risk of not giving a pacifier, but over here the baby got the pacifier. So that's where it's tricky. But as long as you know where it is, your staff knows where it is, they're using it, and then you can show that, walk an assessor through the process. So that's something I know Ann will mention too, but when you have a mock survey or you have an actual assessor come, have someone available that knows where all the documentation is happening and can walk them through that. So if they talk to a mom who says, well, I don't know, they took my baby off and I don't know what they did and I don't know why he left, but he was gone for a long time. We need to know where to go in the chart to find that. So, and I had a question over here.
Is skin to skin with the father included, or it has to only be the mother?
Oh, skin to skin with dad. I think if mom's not available,
Right.
We can do skin to skin with the dad. So.
So there are a lot of people who do that they'll do skin to skin with dad in the OR, and then once mom's in PACU or whatever, then they'll put baby skin to skin. It counts. Even if you don't do it with dad, it counts because mom's able to respond in recovery.
We actually did this, and it was charted. One of the nurses did chart. Mom had general anesthetic. Baby put skin to skin with dad. So, they just chart different things. So, yeah.
Did y'all, Integris folks, did y'all have any cases where baby went skin to skin, say, with dad instead of mom? Right. Right. It's not going to count against you. Right. Right. Okay. Could everybody hear that? So, all right. Let's see how we're doing here. Whoops. Am I too far away? There we go. St. Anthony's. Angela, you want to? Yeah, walk us through. I have to say, Angela's done a lot of work on building the documentation because St. Anthony's is part of a larger hospital system, so this has to go through a lot of hoops because it will be used at many other hospitals.
So we had to meet the needs of, I don't really know how many hospitals are in our system, but I believe there's at least 10 to 15 delivering hospitals in the United States that are SSM Health Care, soon to be SSM Health. They're dropping the care. So it was difficult, and it took almost a year to go through all the committees, and I had to lead a committee for a while with our whole system, and it had to meet everyone's needs because we're the only ones that are this far in the actual baby-friendly process. Some of the hospitals, there's a project in Illinois similar to the Becoming Baby-Friendly in Oklahoma. There's also one in Missouri, and then there's doing something in Wisconsin, which is where other hospitals are. So they're doing some of it. Some of them, they just didn't have documentation and they didn't need it. We also had to meet the needs of the core measure, and so it kind of all got lumped together. I'm a little loud for a microphone. Okay. So we did this. It took a long time. We added all of our skin-to-skin initial feeding stuff in the same column, and so it helps us meet the PCO5, PCO5A, as well as our skin-to-skin and first feeding documentation. Then just because you build it doesn't mean the nurses will chart in it. So that is now what we are working on, is we've had it since maybe July or August of last year, and now we're just stalking our nurses to try to get them to chart in it.
Is that the carrot or the stick? Huh?
I got a report built with Epic. Are any of you on Epic? I kind of like it most of the time. It's like a frenemy. So you can build reports if you have static, or I don't really know what the technical terms are. There's technical people. We tell them what we want, and they build it for us. So all of those columns, those rows of each thing, if they're free text, it's way harder for them to be able to pull a report. So we had to make sure we were building like canned text, and then they can pull in times to columns, and right now we're working on my report so I can finally turn my data into poor Ingrid, who asks it from me all the time, so that we can fix that to take the times and do calculations into my report. So if you have Epic and you build something like this, make sure that your report people are involved so that you know how they can pull those reports for you, so that then you're not spending hours of your life on your report, which is what I'm doing.
Oh, wow. That is sneaky. Yes, absolutely. All right. So let's see. Is that your? So this is this one here. This is on the baby, Angela. So this is on baby's chart, on the baby, and then this is.
This is on the baby also. I didn't wear my glasses. I left them. So this is the main, where all the top little tabs are the flow sheets in the flow sheet area where all the nurses are usually documenting. And then the sections on the left are inside that flow sheet that we're in. So this is the NEO initial assessment, where the nurses are going when the baby is born initially. So all of that, first assessment, just all of the stuff you're documenting at birth. Our hospital nurses wanted this. You can actually make rows show up in different places, and it'll show up that you charted in one area and go another place. You don't have to double document. But the system didn't want it, so we didn't get it. So the nurses lack the follow through, because the nursery nurse or the baby catcher charts here, but the labor nurse never goes back to the NEO initial assessment. So that's been a challenge, because it is really difficult to click on a different flow sheet. Apparently that is it's a huge barrier. I have to click on a different flow sheet to chart, like I'm making them walk to OU Health Science Center to chart something. So that's been a little of a barrier. It's a perceived barrier, because you take your mouse and you like click on it. I don't know. So well, you would think that that's been a barrier, only a perceived barrier, because we're still working on our stuff, so we got to get a lot of buy-in, and that's where we're running into these perceived things that are so hard that really aren't, that you kind of run into in your baby-friendly process.
Create required fields in Epic?
You can, but you have to be really careful. In our system, she asked if you can create required fields, but you have to be careful. And our system does not allow that unless it's like a CMS requirement or something, and baby friendly is not a requirement, and the hospitals are not all doing it, and what we do is what the other hospitals have to do. So you have to be really careful, because then if your baby is sick and you didn't document something, then it's going to kind of stall people in the forms. So it's really hard to get
and generate a lot more documentation as to why not.
Right, and it's just hard to get that approved in our system, so be kind of careful with that. Like, it seems like a good idea, but
So, all right. So this must be on mom.
She asked me about education too, so I just sent her screenshots of everything. This is our breastfeeding section, and she asked me about the pacifiers. So all of our baby education is in the baby's chart. Some places put all the education in the mom's chart because they're educating the mom, but just like a patient that's comatose in ICU, you teach the family, and it's on their chart. So that's what we do. And that avoiding pacifiers in the first weeks is in that first general information under breastfeeding. So I think that's why I sent that to you, is you asked for the pacifier stuff specifically.
That helps to support if they choose to do things that are not like pacifiers.
Right, like if they choose to have one.
Right, it supports you, that you did educate.
That we did that education. Then it's getting the nurses to document as they're doing education and not just waiting until discharge to say it's all done. That's a challenge. And I think I sent you a shot. It's really tiny. Yeah. But when you put your green whatever, when you click on the topic, it actually gives a description of what the nurse should be teaching. So when you have new nurses and they're still learning, they can actually open up the whole thing and not to sell you Epic, but.
So you can hear me. But discourage routine pacifier use during the hospital stay after breastfeeding is well established, usually 3 to 4 weeks. A pacifier should be offered when baby's placed in the back to sleep position to reduce the risk of SIDS. So it tells the nurse what to say, which was, I thought, nice.
And just keep in mind, too, that we will post all the PowerPoints online. So you'll get that link. Well, it'll be on the ouhsc.edu/breastfeeding. But we'll send that out when we send out the evaluation stuff as well. So we'll get all these PowerPoints available. All right, Integris team here. So who wants to speak to yours? Vicki?
All these boxes, we took screenshots and sent out to the nurses so that they would know exactly what to chart for baby friendly. So all those little boxes and arrows aren't there on a day-to-day basis. But this is our skin-to-skin chart, and maybe Kathy can talk more about it. Can you see?
You wanna,
probably the biggest issue we were having with our skin-to-skin documentation was forgetting to chart the end of skin-to-skin. But a lot of times that was because the baby stayed on the chest the whole time, and then by the time we moved the couplet to mother baby, that just kind of got lost in the movement or in reports. So I think we kept it very simple, and if I could see what that said, I might be able to tell.
This one, there's one right back here, too, and if that's a little closer.
I didn't see that.
That's hilarious.
I know. Terry was here. She yelled at me to go get my glasses. So we want, what is this?
Skin documentation.
Oh, yeah, that's what just right there in the bottom is what we talked off, and she had the extra. But we also want to have a chart if for some reason we have to discontinue skin-to-skin early, why. If there always has to be an issue, whether it's mom's unstable or infant's unstable, and then for completion of bonding, we just want to make sure we documented every potential reason for, we wanted to make sure we documented when it happened, how long it lasted, because that's what they want to know, and then if for some reason it was delayed, why we had to delay it or why we had to end it quicker. So it's, even with all those other boxes, those boxes kind of tell you why or how the nurses were taught to chart. So it's really not much to know.
So this is rooming in. So this is still Integris, right? Mm-hmm. This is still y'all's. This is rooming in. An infant location. So, or Vicki or someone, this is your rooming in screen?
Yeah, and I lied a while ago. They did go to one chart. I forgot about this. We had one mother that said the baby was out of the room for a long time and she couldn't remember why. And so, they went there, and if that would be the one chart we didn't document. We're usually pretty good. But this is our infant location. And because it is the standard, we chart when the baby goes from labor and delivery to the mother-baby room, and if they go in and out. So the baby the mom that said that it was a circumcision, and the nurse forgot to chart what time they came back from the circumcision. And what we've heard also is that if you take a baby out of the room to do a procedure for whatever reason, sometimes you have a squeamish mom and she doesn't want to see the metabolic screen or something, and she wants it out of the room. If dad goes with the baby, it doesn't count against you. So if your father goes to the nursery with you, be sure and chart that. And that's a good thing, because our dads a lot of time will go into that treatment area. Even for circumcisions lately, it's been kind of weird, but they've been going in.
Well, and I hope as we've listened to Cammie over the past day or two that we look at opportunities to really empower the mother. She was accompanied Ann and me to do a mock survey at Chickasaw on Wednesday, and something she said at the end of the day in our checkout meeting really struck me when she talked about how we do things to the mother, we do things to the baby, and it helps the mother detach from her baby. That just really struck me. We weren't getting the baby with the mother and and saying, this is your baby and you have the power. You have the power to go with your baby. That's what made me think about it, to make sure the mom knows that if they have to take your baby somewhere, you have the right to go with your baby. You do not have to let us separate you from your baby or have dad go if mom, can't go. But empower her to know that this is your baby. Don't let us take your baby from you.
We try to get radiology to do echoes in the patient rooms because our rooms are big enough, but they will not do them. They have to go to the nursery. So we just send the parents with them, which I don't know what the difference is, but they're okay with that. So mom and dad just go to the nursery with the baby for echoes.
Maybe somebody one day will decide, well, this is silly. Let's just go to the room. So did I see a hand or anything? I don't want to miss anybody. So let's see. So that's rooming in. And then, latch assessment. Yay. So do you want to speak to that, Vicki?
Our goal in what we try to get our nurses to do is every baby at minimum gets one latch assessment per shift. And if that latch score is 7 or below, or if that baby is at risk, late preterm, has weight loss, blood sugar, or mom has maternal pain, then the goal is a latch score every feed until those things are resolved. And that way it encourages follow-up for every feed and success.
Is everybody in here familiar with the latch assessment tool, the latch score? So, okay. Oh, sure.
Are they turning on baby's chart, mom's chart? Are you able to populate it onto the other? Because we have Cerner, and that's one thing I've been asking them. Is there any way you can, because if you try, there's so much information, if you try to do it on both, you're going to not do it the same.
So right now this is all on baby. Okay. And it doesn't populate in mom.
We have Epic, and it doesn't populate to mom's chart either. And we really chose the baby's chart for most of it, partly because of the core measure stuff with all the formula and breastfeeding and everything. And then the skin to skin, I mean, it just makes sense. It's the baby that's on her. I mean, it's hard to decide, but we just decided all of it's on the baby, and the core measure stuff helped us decide because all the education has to be documented on the baby's chart, and the choice of feeding has to be in the baby's chart. And so just that whole section, everything's on the baby's chart in our system.
That certainly makes sense. So is this y'all's too?
This is supplementation for any reason. Baby friendly, let me think about this. Their big thing is that mom's fully informed maternal choice, and they really like it to be verbally said. Joint Commission wants to see that it's documented. The bottom slide is our physician order slide. So when you go in to put a physician order for supplementation, you get these drop-down boxes for, I can't see either. Yeah, it's at the bottom.
This says
At the bottom.
This is breast milk failure reason, and it's maternal medication, infant medical condition, physician ordered, or fully informed maternal choice, and risks and benefits of formula explained are what's in the red call out.
Yeah, and that top that Ingrid just described, that's our nurses' notes. That's where the nurses chart. So if they give supplementation for any reason.
Right. So if you're documenting what they got was as far as what type of supplementation did they get, was breast milk substitute, EBM, express breast milk, or fortifier, and then the indication, jaundice, low birth weight, low glucose, maternal preference, and then it says parentheses after education.
Yeah, because we really want to make sure that the moms have that. Joint Commission, you do, any mother that's breastfeeding, you do have to, if they change their mind, they want to supplement for any reason, you do have to have that physician's order. So that's where we try to capture that. That in the red box, that's just to point out to the nurses that every time we need to have a fully informed maternal choice and that the mother needs to know the risk and benefits, just so that they make sure that they remind them to go over that.
So when you say every time, so maybe one time there was a medical indication, but then what if it's mom's decision and she's been educated, you just do that one time?
At least once a shift. Yeah, once a shift, they kind of reiterate it. And what we do a lot to make sure the nurses are uncomfortable repeating that over and over, so we're encouraging our staff to use teach back, ask the mom what they understand, and if the mom can verbally tell you, then that's good to go. But if you feel like you need to fill any gaps, you can do it at that time. So
Now, did I hear you say that if the mom comes in saying she wants to exclusively breastfeed and then she changes her mind during the course of this day, you have to have a physician order to change the diet? That's
Joint Commission, yeah.
That's awesome. Yeah. So you're already doing that ahead.
Don't we have to have a physician order to change the diet anywhere, usually? I mean, not necessarily with babies.
Yes, you should.
You know where I'm going with that. We just tend to not do it with babies.
To be honest with you, we don't call, if it's the maternal choice, and we know, we will put the order in, and we don't call them. They'll sign it in the morning. They'd kill us if we did that. But and then if it's a medical reason, we're talking to them anyway. So.
Right, but you chart it as that the diet was changed, and the physician signs the chart when they round or whatever?
Yeah, they'll do that.
Okay.
Let's see. Oh, goodness. Okay.
Yeah, and because we're in the process of changing to Epic, they wouldn't let us change a whole lot. If I had my druthers, pacifier would be by itself and not combined with that. But it's just a click that you discussed it with pacifiers. And then we also have a handout. We start teaching about pacifiers prenatally and also in our admission folders to the unit about, just up front why pacifiers and supplementation is going to decrease your milk supply. So that teaching starts at the beginning, and then if they decide to do it, then we check it. But really with that teaching, you don't have many patients that want to do it.
That's the whole point of the teaching, right? Is that we discourage that. So.
This is our discharge teaching. When we made a template of everything that's in our admission. We have an admission folder, and then we have a discharge folder. And on our discharge folder, we have our Milk Moms, our Lalichi League. We have our Oklahoma breastfeeding card that they can call the hotline. I need to add COBA. That's not on there. And that way, it's just a stamp that the nurses can stamp, and then it automatically prints out into their electronic record that we give them when they go home.
Awesome. All right. Okay, well, that's the end of those. So we have a few minutes left. Other questions from anyone? I see a hand. Okay. That's because we're recording.
Okay. We have a hard time with charting things until the very end. That's what everybody does. But we also have a system. We do OBICS. Does anybody do OBICS? No, of course not. We do OBICS, and it can be fixed to where you cannot discharge the patient until their medical record number is in, or until. So would they be accepting of a mini program that is put into a computer, maybe to the baby's chart that says, you better find out when this baby did skin to skin, just for collection purposes. Did somebody chart this on this baby? Did somebody make sure that this baby received supplementation, and did you get a physician's order for this? Will that count as part of the documentation?
If it's outside of your normal system, like a supplement?
But we'll still put it in. We will attach it to our OBICS records and our nursery records, like our Meditech records. That would count.
If it's documented somewhere and you know where to find it, that's the biggest thing, because we can't tell you you have to have a certain documentation program,
Right.
but it needs to be consistent across the board so that if we wanted to look it up, anybody could find it.
And as long as it's going to be in the permanent medical record, you know, when the baby's discharged, just like if you're kind of transitioning to electronic records and you may still have some things on paper,
Right.
well, you've got some things in one computer system, one software system or program, and then something in another, but everybody knows where to find it. Does that make sense? So, yeah. Other questions? All right. Well, we have time for a short break and to kind of reconvene upstairs about 3-ish.